Next, we have Dr. Lathika VK. She is presenting on submacular detachment as a biomarker of therapeutic outcomes in BRBO, a prospective cohort study.
Good morning. My paper is on submacular detachment as a biomarker for therapeutic outcomes in BRVO. Macular edema is the leading cause of impaired vision in BRVO, and submacular detachment contributes a significant proportion of macular edema cases. So it is very relevant for clinicians to know whether SMD impacts the therapeutic outcomes or prognosis. So we have conflicting evidence on this, and that is why the study was designed to assess and compare the therapeutic outcomes following intravitreal ranibizumab in BRVO patient cohorts with CMD and those without CMD. It was a prospective cohort study done in a tertiary care teaching hospital over 18 months on 60 patients who were recruited by consecutive sampling. All patients with BRVO and macular edema who were treatment naive and had a defective vision of less than 2 weeks were included. Patients with coexisting retinal disease and not consenting to participate were excluded. The study population was grouped into cohorts of 30 each with and without SMD, and both underwent intravitreal ranibizumab injections 0.5 milligram, and they were assessed at 2 weeks and 4 weeks following the intervention by the same examiner, and all of them underwent complete ophthalmic evaluation and SDOCT examination. The primary measure of the treatment therapeutic outcomes that we looked at were the BCVA and the CMT reduction, and the secondary measure was the decrease in SMD per se. We also looked at the pattern of therapeutic response, as in which group exhibited a faster response and a more sustainable response. Therapeutic outcomes in each group over time were measured using the pair t-test and the Wilcoxon sign rank test, and the difference between the groups by the independent t-test and the Mann-Whitney U-test, and p less than 0.05 was considered statistically significant. The mean age of our population was around 63 years, and males outnumbered females. All of our patients had hypertension. So coming to the crux of the problem, we found that at the baseline, BCVA was marginally higher in the non-SMD group. Both groups had a statistically significant increase in vision at 1 month and also at 2 weeks. You can see the number of Snellen letter improvements. It was 8 letters in 2 weeks versus 10 letter, 13 letter versus 11 letter. So the highlight is that though both groups improved, there was no statistically significant differences in the BCVA improvement. That means both SMD did not matter actually regarding the final BCVA attained. So but the trend of BCVA improvement over time was different. In the non-SMD group, you can see that in 2 weeks itself, 10 letters improved. Then it sort of plateaued off. That means there was a rapid response and better vision at 2 weeks and almost plateauing thereafter. Whereas in the SMD group, the visual improvement was rather uniformly distributed over 4 weeks. Going on to the CMT changes, the baseline CMT was higher in the SMD group by around 200 microns, and both groups exhibited significant reduction at 2 weeks and 1 month post-injection. However, if you look at the rebound, both had rebound edema after 2 weeks. If you look at the rebound, you can see that it was more and more statistically significant in the SMD group. So what does it say? It says that there is a more rapid, stronger and sustainable anatomical response in the SMD group with less of a rebound happening. We also looked at SMD reduction per se. So the baseline SMD height was 220 microns. It decreased by 51% at 2 weeks and by 63.5% at 1 month. And most of this resolution occurred in the first 2 weeks, probably reflecting in the CMT decrease also. So these are the images showing this therapeutic response, and many studies concur with our studies in that the eyes with SMD has a better anatomical response and comparable visual outcomes, but there are studies in discordance saying that final BCVA was better in patients without SMD at baseline. Actually, the strength and limitation of the study happens to be the same, that is the short follow-up time. Because of the short follow-up, there was nil attrition of the sample, but naturally we could not follow up all SMDs to their complete resolution. So in conclusion, SMD in BRVO responds well to ranibizumab with peak reduction happening at 2 weeks. SMD is a biomarker for significantly faster, stronger and more sustainable anatomical outcome as measured by CMT reduction, but it is not a biomarker for significantly better visual outcome. Visual outcome was actually slightly better in the SMD group, but it was not statistically significant. The BCVA improvement was more rapid in non-SMD group, while SMD took a little bit more time to reach the same visual outcome. So what is new about this study? This study offers new insights into the influence of SMD on the trend and the response curve, therapeutic response curve of the groups in terms of BCVA and CMT. We have studies focusing on the quantum of improvement, but not how it is improving over time. And the specific effect of IVR on SMD resolution per se, independent of CMT, was also studied in this group. And this, of course, is real life data from our part of the world. So what happens next? Why is the relevance of this study? It's because the presence of SMD need not threaten retinal specialists and clinicians. It does not mean a worse visual outcome, though patients may need to be counseled for a more gradual visual recovery. So this study, if translated to evidence-based medicine, can definitely help clinicians set realistic expectations regarding therapeutic outcomes post-intravitreal ranibizumab in BRVO patients with SMD. These are my references, and thank you all for your kind attention.
Is there anything new for which you decided to do this study, which was not there in literature?
Yes, because the role of SMD was more clear in diabetic patients. In BRVO patients, there were studies saying that patients with SMD had significantly reduced vision compared to those without SMD. There are some reports saying that they have a comparatively good vision in the, so there were conflicts between the reports. So when we see a patient with and without SMD, the clinician is rather confused on actually what to expect regarding a therapeutic response. Is there a difference? That is one thing. And we also did not know how fast the differences in the sustainability and the rapidity of the response was not there in the studies. So I think that adds value.
You said none of them have ocular issues apart from BRVO, isn't it?
Yes.
Yeah, but 100% of them have hypertension.
Yes.
So wouldn't hypertensive retinopathy be a confounding factor?
We excluded those with any other sort of retinopathies.
Okay. And
all other retinopathies.
How much of this would you attribute to, for example, BRVO is a very significant event in the patient's life.
Yes.
So the moment you diagnose that and you say hypertension, how much of the recovery from intravitreal could be attributed to the control of hypertension after the procedure?
Actually, all these patients, we take a fitness before IVR injection also. So they were all undergoing concurrent systemic hypertension control as a part of treatment itself. So I think that's equally important.